Good afternoon, everybody, and welcome to this Facebook Live session, which is focusing on the updated Public Health England Infection Prevention and Control Guidance. My name is Liam Brennan. I'm one of the Deputy Medical Directors here at CUH, and infection control falls into my portfolio of responsibility. So we've got about a half-hour session for you this afternoon. I'd like to start off by welcoming and introducing our panel of experts that we have from the Trust here today to help with the session. Can I start off with Jamie? Jamie, would you like to introduce yourself?
Hi, I'm Jamie Whitehorn. I'm one of the consultants in microbiology and infectious diseases, and I've been very involved with the infection control side of managing COVID in the hospital.
Thank you, Jamie. Lorraine?
Good afternoon, everyone. I'm Lorraine Zarametta, Chief Nurse here.
Thank you, Lorraine. Giles?
Good afternoon, everybody. I'm Giles Wright, Associate Director of Workforce, Health and Wellbeing, and I have occupational health in my portfolio.
Thank you, Giles. And Christine?
Hello, everyone. I'm Christine Moody. I'm one of the clinical nurse specialists for infection control.
So thank you very much, everybody, for introducing yourselves. While we get going, and we're going to show you a short presentation now that just summarises the new guidance, please think of any questions that you may have and send those in via Facebook, and we will pick up on those for you after the presentation. So looking forward to hearing your questions. So let's start with a short presentation, which I hope you'll find helpful, and we will make these slides available to you via comms and via the bulletin after the presentation, so that you can use them in your clinical areas as you see fit. So Dale, first slide, please. So as we say, this is updated infection prevention and control guidance that's come from Public Health England, published now about 10 days ago. And the key messages from this are that this new guidance supersedes the existing guidance that was last updated in the middle of June. And importantly, it reflects the fact that we've moved from a period at the height of the pandemic in April, May time, where we had a high community and high hospital prevalence of COVID, into a period of lower prevalence. It hasn't gone away, but a period of lower prevalence. But we are very aware and very mindful that there is isolated outbreaks of higher incidence, and you've seen that from the news around the country of places like Leicester and Blackburn that have had to re-implement lockdown measures. Importantly, the changing guidance, it reflects both the local, the national and the local prevalence, and data is key in all of this. And is being used to guide not only the guidance, but the return to clinical services that we're doing nationally and here at CUH. The guidance applies across the whole of the UK, so there's UK-wide buy-in to this, and it applies in all healthcare settings. So I'll hand over to Jamie now for the next few slides.
Thank you, Liam. So just summarising our local situation currently, we've got as of this morning, no COVID-19 inpatients at CUH, and the current figures indicate that South Cambridgeshire has got a lower rates of infection than the rest of the UK. So 6 cases per 100,000, and the average for England is 8 per 100,000. And the R rate, you've probably heard of the R rate in the media, which basically indicates, it stands for the basic reproduction number. And what it means is the expected number of cases that an individual infection will then generate. And the key is to keep it below 1, because then the infection will start fading away. So currently the R rate for the East of England is between 0.8 and 1, which is lower than the UK average, which is about 0.9 to 1.1. And it's just important to emphasise that we're keeping a close eye on these figures, and the guidelines that we're discussing today are very much influenced by the local epidemiology. Could I have the next slide, please? So essentially what these new guidelines indicate, they've split the COVID-19 pathways into low risk, medium risk and high risk pathways, which in very many ways mirror what we do currently with our red, amber and green pathways. Essentially not much has changed with the high risk group or the medium risk group. So the high risk group are those who've got confirmed COVID or likely COVID. And essentially we manage them as we do currently with scenario 1 or scenario 2 PPE. The medium risk patients are those who don't have COVID symptoms, but we don't yet have a negative COVID result. And again, we would manage them like an amber patient currently, as we do in CUH at the moment. The real difference really is about the low risk pathway. And these are patients who are, they're not contacts of COVID, they don't have COVID symptoms, and they've got a negative COVID result. And they followed self-isolation prior to elective admission, for example. In this situation, there's been a relaxation in some of the PPE requirements. For example, aerosol generating procedures don't require FFP3 masks if patients, they're negative for COVID and we're not suspecting another respiratory infection, for example. Could I have the next slide, please? So essentially the key messages from these new guidelines, they emphasize the importance of maintaining physical distancing, both for members of staff, but also for patients as well, of 2 meters in clinical areas. They emphasize the importance of wearing face masks or face coverings, both for staff and patients. There's been no real change in PPE requirements for the high and medium risk patient groups. However, the low risk groups, there's been some relaxation, but standard infection control procedures still apply for those. And these measures that are being recommended are supported by up-to-date evidence, but also about the local epidemiology, which we are keeping a close eye on at the moment. Can I have the next slide, please? So I'm handing over now to Chris Moody, who will talk about the next few slides.
Thank you very much, Jamie. So as Jamie's already alluded to, it's really clear that our low risk patients, our green patients, or what we would consider normally scenario 0, means quite a huge change for staff working in areas where they've had to deal with patients who require AGPs and up till recently have been using the FFP3 respirator to undertake these procedures. So there are key areas within the trust, such as our neuro wards, who have trachea bays, J2, our critical care areas, and obviously areas like theatres, where this is part of their normal process when intubating a patient before undertaking a theatre procedure. So from an operating theatre procedure, this has really enabled us to get our theatre lists back up and running in a far more effective way than it was before, be able to relax some of the things that we've been able to do in the theatre, because there's always that risk that if you do an AGP, that you have to wait a bit of extra time after the AGP has been performed to allow the particles to settle, means that we can actually do what we were doing prior to the COVID and prior to the COVID surge that we've experienced this year. So from our perspective, no requirement for our patients to be anaesthetised or recovered in the operating theatre because an AGP has been performed. And this has really enabled us to try and start tackling the theatre patients that we've required to get in and make it easier for patients to come into the trust. So this also affects with our critical care areas, because obviously they are an area where a lot of AGPs can be undertaken. So from our perspective, from infection control, it means that we can manage these patients now in single isolation rooms and treat those just as our high risk red patients or amber patients, and the rest of the area can be green, whereas previously we're treating our critical care areas as completely red. So from a staff perspective, this really has made a huge change in their PPE that they're wearing and what they can do in terms of spending more time with their patients and making sure that their lives are far more settled than they were before. So we have to think about the FFP3, which is what we've been using, or equivalent, and you may have seen various different masks being worn by staff across the trust. And it means that we only now need to wear those in our managing of our critical care patients or our medium or high risk patients. So that may be in areas like D10, or sometimes within critical care, or maybe if we're dealing with trachea patients. Next slide, please. So what does it actually mean to be green? For infection control, it means going back to what you would normally wear, wearing your apron, your gloves, and doing your normal precautions that you would do. So you would need to do your hand hygiene before you put your aprons and gloves on. The only difference being is that you would wear masks. That's our scenario 0 scenario that we currently have. So if you are in a clinical area and you are suspecting a patient might have COVID symptoms, please inform infection control and call us and just talk through if you need to regarding any of the swabs that might need taking. If not, we ask that you do swab those patients, and then we can get those patients into a side room and barrier nurse them as we would normally barrier nurse any other infectious patient. So just think about what you need to do. Make sure that if you are going to undertake a swab, that you wear your visor, which will be a scenario 1, whereas normally caring for a patient in a normal green ward would just be scenario 0. We just need to remind you that once you've taken off your PPE, that you would make sure that you undertake your normal hand hygiene and deal with any waste and body fluids from the patient as you would normally do so. There is no change in what you would normally do. And the whole point of this is really trying to reduce any transmission from potential COVID or other infections in the environment from either patient to patient or from patient to staff or staff to patients. So by wearing your scenario 0 PPE, wearing your mask, your apron and your gloves will enable you to break that, what we call a chain of infection, and prevent any spread from these particular vectors is what we call it. If you have got someone who's doing edge-borne AGPs and you suspect that they may have COVID, then you will need to wear your FFP3 as you have been doing so in the last 6 months. Next slide, please.
You're on
Sorry.
me, Chris.
That's me. So sorry. So in summary, our PPE hasn't really changed in terms of what we as infection control always want our staff to do, which is to wear your relevant PPE, do your hand hygiene. But so the risk rating from the guidance is very, very clear. Our scenario 2 and scenario 1 is very much as it was. So your red patients would be scenario 2 if you're doing an AGP, but if you're not doing an AGP, then it'll be a scenario 1. And that goes on to your medium as well, because I'm not sure whether your patient has COVID. We consider them what we call amber. And again, you would need to wear your scenario 1. But for those patients that we're reassured are green, are low risk, as the guidance says, then scenario 0 is what you need to wear. Okay, thank you. Next slide.
Thank you. So just to summarise then, this new guidance, updated guidance, reflects our greater knowledge around the COVID status of our patients and the disease incidence in the community, and our much enhanced testing capacity that we now have. It's supported by, this national guidance is supported locally by our local experts, some of whom we've heard from already, who support this approach, particularly for those low-risk patients, as being safe and proportionate. But we're very mindful that COVID hasn't gone away, and this trust guidance will be kept under constant review to reflect both the local and national pandemic position. So there's just a summary for you and an overview of the guidance. As I say, these slides are available to you, and we'll make sure that they're available via the bulletin and also via the COVID portal, staff portal. So they'll be there for you to use. So what we'd like to do now is to move on to a few questions that have been raised with us over the past few days before we start taking ones live from that you're sending in to us from Facebook. So the first question I was going to ask of the panel, and maybe Lorraine, maybe you could take this one for us, is how will this new guidance benefit our patients and the Trust?
Thanks, Liam. I think both you and Christine and Jamie within your presentation have really covered most of this. But first, I think we now have a better knowledge of COVID. We now have the ability to be able to test far more of our patients as they come in. We have some really good, clear pathways for placements of patients, as well as policies in place to support children of low-risk patients coming in for elective surgery. Which allows us to proportionately relax some of our PPE. That in turn allows us to speed up some of our procedures in areas such as theatres, which Christine mentioned in her presentation. And obviously that in turn means that we are able to treat more patients that are waiting to be cared for by us, which is a massive benefit to those patients out there. With regards to staff, Giles will know more than ever. We've seen this with more and more of our staff who are really being affected by wearing such high levels of PPE. We've had a number of staff that have developed sores on their noses and on their face from some of the FFP3 masks. So not having to wear this for such long periods or at all in some cases is a massive benefit to our staff.
Great, thanks, Lorraine. Anybody else on the panel have anything to add to that? Okay, great, thank you. So if I can turn now to another question that we've received, and please send us in your questions live now. We're really keen to receive them. So a question maybe, Chris, that you could take for us is, are we going to continue with the current scenario approach to patient management? I think you covered it a bit in your presentation, but you'd like to say a few words about that.
Yes, we will continue to continue with this approach. It's worked very well for us as a trust, and I think it makes it really clear to staff, having the posters up, showing them exactly the stages they need to do and putting on their PPE, and it just makes it a lot more easier to maintain the continuity of what we've been doing, you know, during our COVID surge, and maintaining the PPE that we're going to use in the next coming months. Because even though our numbers are low at the moment, we will start to see an increase in patients with suspected COVID. We want our staff to feel reassured, to feel like it's almost second nature to them in what they're actually doing on a day-to-day basis. And I think the last thing we want to do is put another change. It's been a huge change and the staff have coped very, very well with that. But, you know, we do not need to add another change, and we want to keep it simple. So I think it's really clear, and I was really pleased with the guidance saying, you know, red, you're high, this is our scenario 2 or potentially scenario 1 if you're not doing an AGP. Your medium risk will be scenario 1. And your low risk will be our scenario 0.
Thank you. That's really clear. So thank you very much for that, Chris. Giles, if I could turn to you now. Lots of staff and our staff have been very good at doing their personal risk assessments. Will this new guidance affect their personal risk assessment, in your opinion?
I don't think so, is the very short answer. So just by way of remembering then, so the individual staff risk assessment is about understanding an individual employee's risk factors. So it might be a health condition or another risk factor that we've learned through studying COVID. And it looks at their risk of exposure, so the role they have, the area they work in. And then that leads us to a conclusion about safe deployment. So it might be an adjustment to duties, might be moving them to an area where we have low risk patients, for example. So I don't think fundamentally it means that we need to repeat the risk assessments, no. I would, however, caveat that with, if your individual circumstances have changed, then yes, you should, with your manager, revisit the reassessment. If on the back of this you're concerned in any way, yes, revisit the risk assessment, but probably more from the end of the assessment perspective. So what does this mean for me in terms of control measures and additional things I might need to do? So always continue that conversation. And of course, if you're stuck or you or your manager would value some additional input, occupational health, we remain available for those conversations.
Thanks very much, Giles. That's very helpful. So thank you. And then the next question I was going to ask of Jamie. Jamie, some of on the back of this new guidance, particularly for low risk patients, they may feel anxious about not using enhanced PPE for an aerosol generating procedure. What if they feel about that? What would be the Trust's approach to managing that situation?
I think the Trust has got a flexible approach to these kind of issues, and I think we would, in broadly, we would support the use of higher levels of PPE for AGPs, for people who perceive themselves at more risk. So we'd advise people who have those concerns to discuss it with their line managers, and then liaise with the Trust generally. But we would, in practice, we would support high levels of PPE for the use of AGPs in low risk areas for certain individuals.
Yeah, so I think just to add to that, I think this is an approach that we have used when some aspects of a PPE practice have changed nationally, both in theatres and in the critical care areas. We're talking about the high risk situations, but we just to reiterate that, we will take a flexible approach for those management of AGPs in those situations in discussion with line managers. And then the final question I was going to ask, and I don't know who wants to take this one, maybe Chris, maybe Jamie. We talked about the increased testing capacity that we have in the Trust now compared to in the early days of the pandemic. And our strategy for regular patient COVID testing. Can you tell us and tell everybody on Facebook at the moment, what is our approach to regular patient COVID testing and who does that include?
Sure, I'm happy to take that. So I think that at the moment there's a national policy to test every patient on day 0 and day 7. But we're trying to do more than that, and we're doing screening tests in what we deem to be high risk areas, so areas with immunosuppressed patients, some of the transplant wards, for example, and areas also where AGPs are being done on a frequent basis, so that includes D10 and N3. And the idea of this is really to give us give us more information, which will then influence our infection control policies as a Trust. So give us, if we are seeing an uptick in cases in these areas, that will give us a chance to review what we're doing in terms of infection control throughout the organisation.
So really, just to add to that, this is over and above what the national guidance is. So we've put in enhanced testing on top of the national requirement to test all patients at day 0 and day 5 to day 7, where we're increasing.
Yeah, we're going
so just to add to the list that you mentioned there, Jamie, the critical care areas as well. It's obviously an area where there's a lot of AGPs being performed. Okay, so they were the questions that we'd had come in since the guidance had been introduced to the Trust a few days ago. Dale, we've got some questions coming in now. I think, Lorraine, you're going to help us with those and just pick those up and maybe pass and ask them of the group.
Yeah, okay, so we've got 2 questions so far. So the first one is, I'm about to return to work from Shildon, but to a not completely COVID green area and need to do patient-facing work. What type of mask should I be using? Who wants to take that, Christine?
Okay, so what we call the fluid resistant surgical mask, the blue one, should be absolutely fine for you to wear in that particular area. So it shouldn't be any different from what you currently are using out and about, maybe when you go shopping and when you come into the Trust. So what you get given when you come into the hospital at the door is absolutely fine to be worn.
Great, thank you, Christine. And the second question from Carol is, has there been any change in guidance for staff in non-clinical areas regarding surgical masks? Liam?
I'll take that one. I think no, the current guidance for non-clinical staff remains as since we rolled that out in June. That continues as is. You don't have to wear a mask though if you are in a COVID secure environment, and I think we've successfully implemented that policy around the trust. I think everybody's quite familiar with that now.
Great. Okay, just had one more question come in. How will the changes impact in outpatient areas? Some of our patients attend daily for up to 6 weeks. Who wants that one? So how will the changes impact in outpatient areas? Some of the patients attend daily for up to 6 weeks. Unlikely to change current guidance, isn't it, Christine?
Yeah, so yeah. Outpatients will remain the way they have been, which is that we ask patients to wear masks if they can. If they are going to a clinic who need to do testing for hearing or speech and language, then we do actually provide a visor that they can wear, and same for the staff, they can wear a visor with a mask at the end. And it's really about allowing the lip reading to be able to take place. So actually that isn't going to change how we're actually running our outpatients currently.
Great, thank you, Christine. I think they're the only questions that have come in so far.
Yes, that's it.
Thanks, Dale.
Okay, if there were no other questions, I think thank you very much, everybody, for joining us this afternoon on Facebook Live. This presentation and the questionings from the panel will be available and has been recorded, and so will be available through the staff portal for anybody who's not been able to catch it live to see. A reminder that all of the slides are available to you and will be made available to you after we finish today via the staff portal. Can I thank all of our panel for joining me this afternoon and contributing to this session. I hope you found it useful. If you have any further questions about any of this new guidance, please direct them to your own line managers in the first instance. And of course, the infection control team, the infection control bronze team, and all of the experts around this panel today are available to you to help with any questions that you may have. So thank you very much again. Thank you for joining us and have a good day, everybody. Good afternoon.